Hey, everybody, this is Dr. Josh Yellen taking over the sports medicine broadcast for Jeremy Jackson at the Sports Medicine Update here in Houston. We're sitting here with Marney Collins. Marney is an attorney. Tell me where you practice, Marney.
Well, I currently am an in-house counsel for a large school district in Texas, Cypress Fairbanks ISD, third largest school district in Texas. I was in private practice for 8 years before coming in-house.
And so let's just kind of go back in time a little bit. Where did you go to law school?
I went to the University of Houston.
Go Cougs.
That's right.
I am the program director of the Master of Athletic Training program at the University of Houston.
Awesome.
Go Cougs. Go Cougs. All right. So, and then from that point on, you graduated and you went into private practice, right?
I did.
And what was your area of specialty?
I went to work for what was then Bracewell and Giuliani and did public entity law. So I represented school districts, public school districts, some private cities, counties, but primarily in some junior colleges, but primarily public school districts.
So your area of specialty is really in education?
It is in education, public law.
All right, great. So just to kind of set the table here, my bachelor's is in athletic training, my master's in sports medicine, but my doctorate is in educational leadership. And so we learned all about, the legal. You're very familiar with it.
Yes, I actually have co-taught some of the graduate education law graduate classes.
Great. As a matter of fact, my mentor is Dr. Ken Lane. He was at Southeastern Louisiana University. He is the president of the Educational Law Society. So he was my dissertation chair. So I really focused on legal and ethical and regulatory concerns, and I apply that to athletic training. And so let's kind of move into the conversation. So right now, and the last time that I was on the show with Jeremy Jackson, we had Josh Woodall on, and Josh is the president of SWATA, the Southwest Athletic Trainers Association. He is also a high school-based athletic trainer in Bryan ISD. And so we talk about how athletic trainers, the high school-based athletic trainers, there's a lot of talk right now about secondary school settings. And obviously there are some student athletic trainer programs, what we call student aids. You know, the NATA says that there are student aids, and they put out position statements about all that. And they talk about what the student aid should be used for, so on and so forth. So we're going to set that part aside. And let's go back in time a little bit. If you're a high school-based athletic trainer anywhere in the country, you have to be familiar with both FERPA and HIPAA.
Correct.
So for those that are not familiar with FERPA, because, right, healthcare provider, I may not be familiar with FERPA unless I'm in secondary school setting or at the university. Explain what FERPA is, explain how it came about, explain how it merges or how it's similar to HIPAA.
Well, FERPA stands for, which is funny, educators, we like our acronyms, and FERPA almost sounds like a bad word, but it's the Family Education Rights Privacy Act, but we all just call it FERPA. And I want to say it came about as some of the, shortly after some of the civil rights litigation. I believe it's 1974 approximately, but it's a federal law. And I explain it when I'm explaining it to school personnel as well as parents. It's both a sword and a shield. It's a sword in that it gives parents an absolute right of access to the records of their children, and then as an adult student, the absolute right of access to your own records. But it's also a shield in that it limits the third parties who will have access to those records, except certain enumerated exceptions. The most common one that we deal with is if you are a school official with a legitimate educational interest in the record, then you may have access to the record without parent permission. But generally speaking, if the exceptions do not apply, you have to have parent permission in order to access records. So that's how it is similar to HIPAA. HIPAA, of course, is a federal law that was passed in order to bring, as I understand it, uniformity to how medical records were shared, particularly those that were shared electronically. But for those who provide healthcare services in the educational setting, I think it's a little bit easier for you all, because there is a specific provision within HIPAA that says if FERPA applies, then HIPAA does not.
Yeah, right.
So as an athletic trainer, if I have a treatment record on a student athlete, I have anything that I am maintaining as part of my job as a school employee who happens to be an athletic trainer, then FERPA actually applies. And it's a little different because sometimes that accessibility may be a little bit different than you might have in private practice. And what I mean by that is parents, I'm going to get this sometimes with my psychologists, in-house psychologists, when they're unsure what they can disclose to a parent out of their files. And I try to explain to them, pretty much everything in your file, a parent is going to have access to. So it's always good for employees to remember that.
As long as, and correct me if I'm wrong, you're the expert in this area, as long as the student has given permission in a college setting, as long as the student has given permission to the parent.
I'm sorry, you know what? Thank you for that clarification. I forget that we're not just dealing with K through 12.
Right.
Yes, college, you are correct. Once, and that's why I alluded to it earlier, and I should have been more clear. When I say a parent, I always should say also, or an adult student, because once that student turns 18, those rights move to
it's very similar to HIPAA, right? So
yes.
I have a child, right? My kids are 15 and going to be 12. By the way, my wife is getting her second master's degree as a licensed school in Texas. It's not a school psychologist; it's a licensed. Right. So she's finished her second master's degree. Just a side note, between the two of us, we'll have 3 master's degrees and a doctorate, and we're going to be the poorest, smartest people you'd ever met. Okay. So back to the HIPAA and the FERPA. So FERPA in the secondary, right, K through 12, the parent always has a right to see those files. Is there anything that the administrator needs to do or needs to know to release those files to the parent?
Well, and again, K through 12, and even in once you get to 12, you may have an adult student. So when I say parent/adult student, there may be an extenuating circumstance where you might be allowed to withhold that record in a health and safety situation. But generally speaking, yes, they're going to have an adult student or parent's going to have a right of access. One thing to keep in mind, typically as a best practice, I do advise that you get that request for disclosure in writing, and that you maintain that in accordance with your record retention. And but generally speaking, yes, it's going to be an absolute right of access.
And then so let's go back to something you said before about a legitimate right to know. So you have an athletic trainer in the secondary school setting. So let's just stay in the K through 12 realm right now. You have an athletic trainer in the secondary school setting, and that athletic trainer is treating a student athlete, football player, basketball player, whatever it is. And that athletic trainer has a legitimate right to know about what's happening because they're medical records. Let's say a coach intervenes and says, I want to know what's happening with, child ABC, whatever it is. Does that coach have a legitimate right to know? Or is it one of those things of, I can only tell you so much information?
Well, that's a good question as well. And whether it is a coach to an athletic trainer or a classroom teacher to an athletic trainer who just has a special interest in Johnny. Hey, I saw Johnny on the sidelines Saturday on your table. Is he okay? I mean, a legitimate question. You always have to apply the filter that says you have to, really 2 parts in order to have access to the educational information under FERPA. You need to be a school official.
Okay.
But the second part is with a legitimate educational interest in the information.
Right. So let's define, what is it in the state's eyes? What is a school official?
Well, and under FERPA, the federal law doesn't define it, other than a school official would be someone by local policy. You would look to see if how you have defined that. And so typically in our code of conduct and handbook in our school district and most across the state, they will give notice to parents. Here's who we consider to be school officials. FERPA doesn't define it, but does require that you define it.
Okay.
And so you would look to your local handbook, your local policy, wherever you give notice to parents. So a parent could know that a school official can also include a contractor. So say you are not a full-time athletic trainer, you contract through a local hospital, you would still be considered a school official if you have correctly defined it in your notice to parents.
So it's autonomous to each district, or is it autonomous to each school?
Well, it is typically autonomous to each district. It could be autonomous to each school if you defined it as such within your policy.
And is it consistent for both public and private schools?
Well, FERPA does not apply to private schools. And so, but I would imagine that I have not represented an extensive amount of private schools, but those that I have been larger schools, and they have modeled their policies and practices after those. And so I would imagine for accreditation purposes, they are probably required to have the same level of confidentiality and the same type of disclosure.
Okay, so let's move on and let's talk about, you're going to give a presentation here in a little bit. Let's talk about documentation. And I always have a statement whenever I teach the administration class in our Master of Athletic Training program. And one of the first lessons I teach them is CYA equals CYA, right? So cover your fill in the blank equals see ya, go get somebody else. Because I have a chain of documentation. I have documented everything from recommendations to how the patient responded to treatment, to those who I communicated with, to my recommendations, to all those different things. And so we're documenting. And so under FERPA, we have to document injury records, right?
Well, that's probably a best practice.
Okay.
FERPA doesn't require that you create records, but once you do, you have to maintain it and you may have to disclose it.
And so let's talk about that, and let's put the elephant in the room when it comes to injury. The hot topic these days is concussion. And so you have a lot of medical professionals now that specialize in concussions and are talking about return to play, but there's also some return to learn guidelines. In these type of situations, tell me a little bit about the responsibility of the treating athletic trainer, the treating physician, and let's complicate things a little bit more. The treating athletic trainer is employed by the school. The treating physician is not, but could be a contractor. And who are they going to communicate with to set up proper intervention for that student? And then I want to kind of work into the IEP realm.
Well, ideally, they would work directly with the parent, and the line of communication between the parent and the school staff would be open and flowing. And if necessary, permission would be granted by the parent for communication to occur directly between the athletic trainer and the doctor. But ideally, particularly with the doctor, the physician, that communication is going to be between the parent and the physician. Then they're going to be clear in their either restrictions or recommendations, put that in writing, then can be provided either directly to the athletic trainer or the parent provides what the physician has provided.
So there are a lot of moving parts in this, right? And so let's kind of back up and make sure that I'm following you. One is the athletic trainer sees that athlete, right, and diagnoses them with a concussion and refers out to the treating physician who confirms the diagnosis.
Yes.
Okay. It's a minor, so we'll call the minor Johnny, right? And so the minor is Johnny. And now the athletic trainer and the physician are communicating directly with the parent and are telling the parent, look, Johnny's been diagnosed with a concussion. These are the guidelines and parameters that we want to put in place, and we're going to start our concussion protocol. Okay. Now, whose responsibility is it now to communicate with the teachers? Because Johnny has been diagnosed with a concussion and is more than likely going to be sensitive to light and is going to have trouble in the classroom and may miss an exam and may have trouble studying, may have trouble concentrating. So at that point, assuming that the parents have not given permission for the athletic trainer or the physician to speak to the teachers, it falls on the parent's responsibility, correct?
It does. I would say, however, if you've got your athletic trainer who is employed by the school district, and so he or she would be getting the information from the parent, I would say ideally both the athletic trainer and the parent would be communicating with staff. The trainer can disclose information to the parents to the teachers without parent permission if they are, our two-part inquiry, a school official with a legitimate educational interest. So opposed to the teacher just wanting to know how Johnny was doing because he's one of my favorite students and I happen to follow follow football versus I teach Johnny English, and right now we're reading Beowulf. And, besides the fact that reading Beowulf in and of itself without a concussion is hard to do, but, so Johnny may not be able to sit and attend to task like that. And so it would be appropriate then for the athletic trainer to say, here are the restrictions we've received teachers.
Right. And that's what I want our listeners to understand is that, listen to the expert, listen to Marney and how she's explaining the different parameters of what the athletic trainers can and cannot do. And the two things that you outline, I think the conversation, the two themes that they need to understand from this conversation are, one, it's a school official, the athletic trainer is a school official, and two, they have a legitimate right to know, and that their communication to, the art teacher, because maybe they tore their ACL, that art teacher doesn't have a legitimate right to know, and they're not a school official. However, if it is an English teacher and they are studying and the English teacher is concerned about Johnny's progress in class because the amount of mental work that's going to be put into it, well, at that point, that is a legitimate right to know.
Yes, absolutely. It's a legitimate reason as opposed to just wanting to know out of curiosity. Okay.
So now let's move in and complicate some matters some more. Shall we? Great. I love it. All right. So Johnny's been diagnosed with a concussion, and this happened on a Friday night, and they have an exam on Monday, and we know treatment protocols for concussions different than when I played, decades ago, that there are different protocols in there to try to protect the brain. And what we realize is that we need to just shut the brain down and have some rest. So Johnny tries to return back to class and is having trouble. Speak to us from a legal aspect. There is now some return to learn protocols and return to play, sure, but return to learn. At what point do you recommend that, we may need a IEP in place. We may need a 504 in place.
Right. 504 would more likely be the scenario that you would find if the student hadn't otherwise qualified for specialized instruction. And so really what I've come to learn in my position just from dealing with different students is that concussions affect everyone differently. And we may have a student that does not struggle with some of the attention to task and things where another student with a similar or maybe even what appears to be less severe concussion does. And they develop persistent symptoms and they just struggle with returning to the classroom. And so I've seen that a couple of times over the years. And so what we have done once we recognize, and that's really the recognition is a collaborative effort between, the athletic trainer saying, this is what I'm seeing, and the classroom teachers, sharing that. Oftentimes counselors are a good center for information because the teachers will often communicate with the counselors. And then sometimes the athletic trainers will communicate with the counselors as far as accommodations. And so what you would then need to do is work with the physician, determine if the student has a concussive syndrome, something well beyond a typical concussion. And if so, then they may qualify. They may have a student with a disability who, with or without reasonable accommodation, will need something in order to access the educational program. And so you would put together a 504 plan, committee first, determine if the student does need modifications or accommodations, and then the key people in place, and that could include your athletic trainer on your 504 committee to talk about some of the health aspects of it.
Well, we're getting the signal that I think that you're ready to rock and roll. What I'd like to do, if that's okay, is continue this conversation. I know that you don't have any time after today because you got to get to a meeting, but maybe we can go back to Pasadena High School with Jeremy Jackson, continue with this conversation because I have a whole nother list of questions for you about duty, breach of duty, negligence, tort law, all those other things.
Yeah, so you've got some immunities as public athletic trainers, not just under the Good Samaritan or, I think it's the Good Samaritan law. I don't remember the shorthand version, but you also, if you are a school volunteer, so if you are working for a hospital, but yet you volunteer, then you're going to have some immunities, even though you're not an employee. Of course, as an employee, you have some of the strongest immunities under state and federal law, but there are other things that protect you as first responders.
So let's plan to continue this conversation at another time. That's up to her. I don't want to disclose the information. If somebody wanted to contact you and ask you some questions, how would they do that?
Well, I am actually in-house, and so I don't have a private practice. So I'm just at the school district. I would be happy to to bounce ideas off of someone or collaborate. I work directly or closely with Robert Maniscalco. He's looking around like don't say my name, but and so I work directly with some of the trainers at Memorial Hermann. And so I'm Marney Collins Sims, and I'm the general counsel at Cypress Fairbanks ISD. But there are many education lawyers, and I think we all probably could be better served by learning more about the athletic training community and working together to better serve the kids.
Great. All right. I think
Thank
you're ready to go.
Okay.
Thanks.
Nice to meet
Thanks,
you.
Marney. Nice to meet you too.
I'm gonna put you right on stage.
Okay, perfect.
Thank you from Dr. Young. You'll be here. This is fancy.
Yeah.
Oh, she's pretty sure.
Well,
Well,
Thank you.
All right, so for listening live, all of these will be found later at sportsmedicinebroadcast.com/first name, last name 2016. So that was Marney Collins. Oh, I don't know if I put Collins Sims. How is she listed in the just Collins? All right, so I think it's Marney Collins. So Marney, sportsmedicinebroadcast.com/Marney Collins 2016. So whenever it's published, it'll be a little while, but make sure you look for it like that. All right. All right. So it continues to stream live. Chris.
Hey, Jeremy, Chris, pleasure. Yeah.
So each of these, if you'll remember to say it, is sportsmedicinebroadcast.com/Chris Juneau 2016.
Wait, I need you to write this down.
First name, last name 2016.
I need you to write that. You did, but I'm not going to. Okay, hang on.
I got a pen.
You,
Jasmine, you got a pen? Jasmine.
okay, hang on. Hang on. I'll pull it up. Okay, so it's going to be sportsmedicinebroadcast.com/Chris Juneau 2016.
Yep.
That's what it is.
Yep.
I got it. Okay, here, let me write this thing down. So, wow, that's quite the pen, man.
It's fancy. Something to be said
I feel it.
about a man with a good heavy pen. Oh, that's nice. Mm-hmm.
Yeah, right. That's a nice conference.
You probably got a nameplate with that pen too, huh?
I don't know whatever name. I think it says Love Knocks, which is
Whatever, dude.
awkward, but I think it's like a painkiller.
Lowe, I think, is it's an assistive diuretic. I think. Is that right?
I was at the UTMB in Galveston, I think is where I got that. Not, I don't know if it was UTMB, but it was UTMB Galveston, I think is where I got that.
Okay, this is Dr. Josh Ellen again, sitting in for, no, we're ready to go? Ready? All right, here we are. Dr. Josh Ellen again, Program Director, Master of Athletic Training Program. I have commandeered the sports medicine broadcast from Jeremy Jackson, and we have taken over, and this is our plan for world domination. Okay, so we just finished up with the first part with Marney Collins, and Marney is legal counsel at one of the school districts, and that was a fascinating conversation, and we will continue. And now we're sitting here with Chris Juneau, physical therapist with Memorial Hermann, the Ironman Sports Medicine Institute, correct?
That's it.
And from one bearded fellow to the next, well done, sir.
Well, hey,
I mean,
try
that's
hard.
nice. I mean, that's impressive.
I got a climb coming up to Kilimanjaro, so
Really?
Yeah, so I'm really trying to just.
Do you really have a climb coming up?
Absolutely.
Are you a climber?
Absolutely not.
And so
We're gonna hike the top of this mountain, my friend.
okay, pal.
Me and a couple boys we're gonna get to the top of this thing.
And just tell me how you got to this point. So it was one of those things of like you all are sitting around and maybe having some, I don't know, we'll call it
campfire going wrong.
Yeah,
right?
we'll just call it.
Yeah.
I have this picture in my head of the movie The Hangover. And it's like somehow all of a sudden one of you get this brilliant idea, dude, we should climb Kilimanjaro.
So it's actually a funny story. So my cousin, and this was late December, he texts me, and I don't have his number at the time. So I get this blank text that says, hey, let's go climb Mount Kilimanjaro. And, me being the person I am, I reply, absolutely. When are we going? Who is this? So he replies back, it's your cousin, and thus the plan
which one?
was
Like you have one cousin.
was created, and here we are a month out.
And so you're going to go in July.
Yes.
Okay.
Mhm.
And you're going to just go climb.
We're gonna go
And
climb.
just
this
to
thing.
clarify, you are not a climber or a hiker.
I mean, I'm
Like
a
you can
hiker.
walk. You're
Yeah,
a bipedal
Sure,
human being.
sure.
We
I've done
get
some
that. And,
hiking.
and you've climbed up stairs before, surely.
I have 2 today specifically.
surely,
so
yeah,
they
right.
felt good. So.
And then, like, if you've fallen, you surely have pulled yourself up.
Right.
Okay,
I
so-
imagine myself like cliffhanger.
So if we're
But
going to
just with a better
scaffold
beard.
these concepts
Sure.
together,
Mhm.
okay.
Yep.
All right, great.
We're home.
Perfect. That will lead us into dry needling. So let's talk a little bit about dry needling, right?
Sure.
This is again one of those kind of hot topics. You know, it came on like a thunderstorm, man.
Mhm.
And it was one of those things. This is going to be the best thing since ART. It's going to be the best thing since Graston. It's going to be the best thing since ASTEM. It's going to be the best thing, right? And so one of the things I liked about your presentation is that, you know, it is a tool in the toolbox.
Right.
And so let's kind of talk a little bit about the theory of dry needling.
Mhm.
Let's talk about when to use it, when not to use it. Let's talk about the difference between dry needling and acupuncture.
Sure.
And then let's talk about who can perform, you know, dry needling,
Sure.
who can't, and when, you know, what were some indications and contraindications. So let's start from the beginning, right? Dry needling is what?
So dry needling is the use of a small filament needle
Mm-hmm.
that is non-hypodermic, certainly not gauged, and it is for the use of soft tissue pain, neuromuscular pathologies, and that's definitely a more Western-based definition. That's from the FSBPT,
And for those people that don't know FSBPT,
the Federal Board of State Physical Therapy.
uh-huh.
And they've been, I don't want to say forced, but hand bid into describing this because it's such a popular
Sure.
topic, and because and this tangents into your next question about acupuncture, because it looks very similar.
Right.
And that's where people get confused, but it's you're really using the term as semantics to define the profession, and it's inappropriate, right?
Mhm.
We would never say that a calculator would define an accountant,
Right.
just as saying that a needle would not define an acupuncture or a dry needler.
Mhm.
Acupuncture is very much Eastern medicine based. It uses things like qi, yin and yang, and meridians,
Mhm.
ashi points, all of which I honestly could tell you very little about because it's certainly not the training that I've had.
Mhm.
And that's a primary intervention strategy. I mean, you would seek out an acupuncturist, you would receive their treatment, which is acupuncture,
Mhm.
and then you go about your way. They also treat things like smoking,
Mhm.
the common cold, infertility. All of these things would be so far beyond the scope of Western dry needling,
Mhm.
which is very much based on tangible structural problem,
Mhm.
motor recruitment, soft tissue trigger points, scar tissue, things of that nature. So it's definitely, when you're talking about dry needling, it's important to appreciate that it is a secondary modality, and like you said, a tool in the toolbox.
Mhm.
I would never encourage, and I actually teach, so I do have to give that disclaimer. I teach for Kineticor, which is one of the certification
Fine.
companies.
Even better.
But when teaching, we make it a point to encourage all participants that this is a treatment approach. There always needs to be, some reiteration behind it, a corrective exercise, some home exercise program. This is certainly not going to be the lightning strike or the magic pill that's going to save your patient or
Right.
client.
And that's what I want people to understand is that when other therapeutic interventions came across, and let's go back, I've been practicing for just about 20 years.
Mhm.
I remember when laser first
Sure.
came on, and man, everybody was buying laser. And what did we figure out? Well, it maybe it does, maybe it doesn't. We don't really know. And then, of course, there was before laser, it was ultrasound. We're going to ultrasound
Right.
everybody. And what did we figure out? Well, it doesn't really work in that chronic setting. It works more in the acute setting, and I can use non-thermal effects for cavitation And okay.
Absolutely.
And then, along the lines with ultrasound, why does the time keep on moving up? Because the insurance companies told you to. All right. So then we got into, laser, and then we kind of kept on pushing the envelope. And then when I was coming through, it was, towards the end of my curriculum, it was active release. All right. Well, this looks a lot like myofascial release 4. And then, it's going to be Graston. Well, this looks a lot like scraping in the back of a reflex hammer and skin lube. And then what about A-stim? Well, that's different. And so all these different things. And then obviously NASM came on, you've got PES and CES.
Absolutely.
And man, boy, these people have a lot of initials.
Lots of letters.
And what does this mean? It goes back to a concept you just said. I love it. It's in your presentation. The calculator does not define the CPA. The tool does not define the clinician. So let's kind of go back to dry needling and talk about how did it come about? Obviously acupuncture has been around for thousands of years. And by the way, let me interrupt. This is Stacy Latham. Come on in, Stacy. Stacy is an athletic trainer, and she is employed by Wiley and contracts out to NASA. So she is what's called an astronaut strength conditioning and rehabilitation specialist, or an ACER. And by the way, there are only 2 full-time ACERs, athletic trainer ACERs, that work directly with astronauts. Stacy is one of them.
Your credentials sound cooler than mine, Stacey.
How about that?
It is a job title that almost sounds fake.
Yeah, it's really awesome. Stacy just recently flew to Russia, and she did some neutral buoyancy lab training, and it's really cool.
Stacey.
I mean, it's really cool, right? It's really cool.
It sounds fake. No one believes that I actually do it. It's pretty amazing.
So let's go back, Chris, and talk about dry needling, right? Acupuncture has been around for thousands of years. They use, meridians and stuff like that. By the way, the meridians look a lot like the Langer's lines, right?
Sure.
Yeah. I mean, they look almost identical.
So much carryover.
Yeah. Right. And it's like, okay, well, so how did dry needling come about? How was it discovered that, we can take maybe some concepts of, and correct me if I'm wrong, some concepts of acupuncture and refine a little bit more and just work on myofascial issues?
Sure. Well, I think most people would report that the inception was based on trigger point injections, lidocaine injections into local trigger points that were reporting, somatic-based pain. Physicians and pain physicians specifically will inject these areas with a local, and the patients would feel better. Well, they ran a trial against the lidocaine and just simple saline, and they found that there was, certainly small difference.
Yeah, there were no significant findings.
Very small, insignificant findings. And so then they thought, well, it may be best to compare the saline to just simply sticking a gauge needle into these areas. And what they found was exactly that the needle actually had a profound impact on the tissue itself, not necessarily the liquid solution that is being injected into the area. And then this kind of snowballed, and Travell and Simons, and with their concept of trigger points in general, and eventually evolved with Dr. Shaw's study. And I want to say, and I always forget I think it's 2010, but they looked at the chemical environment of a trigger point pre and post insertion of a metallic object. And they found that the local mediators, these chemicals of the area, were changed for the better. And I get into a little bit of that in the presentation about specific metabolites and chemicals, but for the sake of time, it really changes how you perceive the area and the way the area is being perceived by the brain.
And so obviously that goes into some different theoretical models of gate control, endogenous opiate, central biasing, that kind of, but probably more like gate control, endogenous opiate, less central biasing.
For that specific model, correct.
So let's stay on this topic. So now we kind of understand the differences of acupunctures. They have one purpose, and the dry needling was really, I think, a misunderstanding of a lot of people is that, they just took some acupuncture models and theories and they refined it, but it's not really the case. No. It was really more based in Western medicine, and what they figured out was it really doesn't matter the lidocaine or whatever substance we're using. It's really the needle that's causing this intervention. So We talked briefly a little bit about in the beginning, who can perform dry needling? So we know PTs can.
Sure.
Right. In most states, is it all states now?
It's not all states, and
Yeah.
there's a few that will never be.
Yeah.
It's just the way the Practice Act is written. For instance, California and Florida.
You know, I'm originally from Southern California,
Yeah.
and I'm just going to tell you, we're just weird. We just.
Well, I agree, right?
I mean, I'm just telling you right now.
So there's a couple of states that have chosen to take a stance that says you can't penetrate the skin, or a variety of language that has prevented PTs and other scopes of practice from utilizing dry needles. And so that's always on the forefront. And just recently, we actually had in the state of Texas, the Attorney General ruling on dry needling, which ruled in our favor, which was a massive
It's huge,
win.
because before it was kind of a gray area, right? Like it was like, well,
Texas was gray.
Yeah, you can't, but you know, you can. It's not. I'm not going to tell you can. I'm not going to tell you can. I'm just not really.
It's more about liability,
right?
It's ultimately about liability. Who's going to stand up for you, and that gets into your question: who can perform it? I mean, there's obviously no way that we could stop anybody from using a needle on another person, patient, client, et cetera. And it happens throughout the country where some people or educators, even clinicians, may be teaching their staff members or instructing that. And again, is it unlawful? No, but as a company speaking, personally, there's no way we would stand up for that. If something were to happen, we certainly could not come to your aid if something were to happen. And so it's about liability and certification, you know, and competence.
Yeah, it's about training. So in both Texas and Ohio, right? Athletic trainers can perform.
And that's just what I know. There's no telling. It's such a wild west outside of PT right now, because people are seeing success in PT, and athletic trainers and PTAs, LEs, massage therapists are all seeking the ability to utilize this tool. And again, they're back where we were a decade ago. And so the landscape is so dynamic. It's hard for me to even keep track of which states are on, who's off, who's in litigation, who's not. It's very difficult.
And really, like, I know right now, Sue Falsone is traveling. I think Sue is great. Did she set the world on fire when she was with the Dodgers?
Yeah,
right.
I've spoken with her.
Yeah, and now she is on faculty at A.T. Still University. The vice president of the Commission on the Accreditation for Athletic Training Education, Dr. Eric Sowers, is the chair over there at A.T. Still and hired Sue.
Oh yeah,
and she's outstanding. And so you have some athletic trainers in Texas that are going to take the course. And one of the things that probably needs to be known is that this is just like anything else. It's like CPR. It's like anything else. You better have gone through the training and shown that you have completed these clinical proficiencies before you perform this, right? I would never go take a needle. I would be stupid.
Absolutely. I mean, and that's what the FSPT really sought to establish. I think about 6 months ago, when they came up with the core competencies needed for dry needling, and what was agreed upon, that the psychomotor skill of using a needle, inserting it into somebody's skin, that can be learned in a continuing education format. You can take a weekend course with enough accredited CEUs, and you can certainly learn the psychomotor skill of employing the needle. However, that is based on the fact that you have achieved preliminary education in anatomy and biomechanics, and in specific anatomy, not just superficial, because you really need to know 3D anatomy as it relates to the body, obviously, because you're going to be penetrating multiple layers of tissue.
Right.
And so the assumption, I mean, again, with all of this, is that certainly we have the education, and I'm speaking as a PT, we have the education because we have the background, not because we took the competency seminar over the weekend. I mean, that's where the hot water starts to boil. Is there's no way you can teach somebody dry needling in a weekend. You don't have the education. As acupuncturists has these 3 to 4 year programs. I couldn't agree more. However, we do have 3 years of most cases of PT school, which is a clinical doctorate and an amazing background in anatomy and physiology. And so we do have the background, just not in the psychomotor aspect of things. And so that's usually the format that we take as it relates to why we feel that we're able to perform dry
Sure.
needling, and why others, if you don't have that background, if you're an LMT or an athletic trainer, depending on your background and depending on the coursework,
Mhm.
it may not satisfy
Mhm.
what we would feel to be adequate anatomy and biomechanical understanding.
Right. And I think that on that, I think that as athletic training moves into an entry-level master's, this
Absolutely.
is what we tell all of our students is that, they all have bachelor's degrees in exercise science and so forth, just like PT would. And then they come to AT school where they just focus specifically over 6 semesters. This is what you're learning, so that they are qualified to go and they are qualified to be recognized by CMS to provide these interventions, because CMS just won't reimburse for a baccalaureate level provider.
Sure.
All right, let's move on and talk about the physiological effects of dry needling. Tell us a little bit about how, what are the mechanical effects? What are the electrophysiological effects? What are the chemical effects?
Right. So if we speak chemically, the Shaw study looked at pH, and we would all appreciate this concept. Pain is hot. Hot is acidic. Lower pH is hot. So by that format, we would feel that most somatic referred pain or trigger points are achy, dull, kind of burning sensation. And so you can raise the pH by limiting and helping disperse some of the hydrogen atoms located in the tissue. They also found other things like CGRP and substance P. These are just pain-inducing metabolites in the area that you can also help flush out. It's basically opening the garbage chute and letting these things out.
Sure.
The other aspect is changing the local endpoint, and this is, again, more of a local treatment response where you're changing how the motor endpoint of the nervous system is functioning. So, so the axon ends at a new dendrite. That endpoint right there is facilitating activation. And what happens is it gets turned on and doesn't get turned off. And so you have this constant buzz, and so you have this chronic holding state. The needle itself, via the electrophysiologic response, helps, again, shut down that SEA or spontaneous electrical activation to help relaxation of the muscle. And then finally, speaking more of a neuromuscular component, one of the areas that is relatively newer way of thinking, but the muscle spindle lives inside the muscle in the bag inside the muscle belly, and it has a couple of pertinent pieces to it, the alpha and the gamma neuron, and your central nervous system is controlling your muscle via these two these two structures. The gamma is more important because it's basically your sensitivity device. It's telling your muscle how tight it needs to be for adequate muscle function. If you didn't have the gamma, your muscle would shorten, but then would lose tension. Right, and so you have to have that feedback. And what we think is that this gamma neuron is working inappropriately, and so it's telling your brain that bag weighs 50 pounds when it really only weighs 5.
Sure.
So it's so upregulated that your quality is so far diminished, and the insertion of the needle is changing, almost like a resetting device. It's turning the computer on and off and allowing things to normalize. By what mechanism? There's a ton of hypotheses.
Yeah, bunch of theories.
Bunch of theories.
Right? So what this leads me to connect is, before we had dry needling, right? If we were going to isolate a trigger point, we would use this combo, right? Ultrasound, E-stim, and the theory was it was doing the exact same thing, right? And so has there really been any efficacy studies on the difference between dry needling and the use of combo therapy on these trigger points?
Probably so. I can't speak to that directly. I'm sure there have been. The biggest question is depth and specificity of the electrical current. That's probably going to be the greatest argument. The nice thing is, I'm sticking an electric object to a specific depth of which, I think to be the tissue I'm targeting, and running current straight through that. So I know exactly where that's going. With combo and things like that, it depends on distance apart and
we don't have to deal with ERA. We don't have to do with half layer value. We don't have to do with anything.
So it's a good point. I mean, I certainly agree with what you said. I don't know anything specifically though.
Let's just say that you are in a setting, right, and you choose through your evaluation you're gonna perform dry needling.
Sure.
Insurance can reimburse for it?
Technically, no.
Will insurance reimburse any healthcare provider for it?
Oh, that's a tricky question.
I like tricky questions.
Yeah, right. The answer would probably be yes. Currently not PTs.
Mhm.
I would imagine if you're a chiropractor and or if you're running through insurance as a physician, I would imagine they would. I don't know that directly.
Mhm.
As a PT, they have the insurance companies. Now, I'll be clear, some actually have, but you have to go to them directly and they have to give you a specialized code to
Mhm.
use. That's where the
Because
tricky
it's
part.
outside the normal.
Correct.
I forget what that acronym is, but it's outside your normal.
Correct.
Usual and normal billing, something. I forget what it is.
Right. And that's correct. And so there are codes that you can use, but they would be inappropriate. They've made a stance that the manual therapy code 91470, I think, is inappropriate for the use of dry needling,
Mhm.
which is where most people were billing it. And so what tends to happen if it's going through insurance, most people don't bill that. They choose not to bill it and they bill for other services provided.
Right. So I may get a dry needling session, but I'm, as a provider, I'm just not going to bill for it.
Right. I'll
I'm
bill
gonna-
for the manual and et cetera.
Right.
Sure.
Okay. Let's keep on going and talk about, in your clinical practice, when is dry needling most effective and when is it not? So let's go back to the tool. You go through your clinical evaluation, you make your diagnosis, and you go through treatment. Obviously, right, you're not going with the needle first.
Right.
You're going to go through this algorithm of treatment protocols. In your opinion, when do you bring that needle on board and when don't you?
I think any time that manual therapy is indicated, if you're using Graston and ISTEM and cupping and this huge array of tools and battery that you have, then it's indicated. And personally, if I'm going to do any aggressive soft tissue, specifically locally, and even more so if it's deep tissue, deeper gluteal musculature, the rotator cuff specifically, where people don't tolerate a whole lot of aggressive palpation or Graston, and you really have to get those stoic creatures in there if you really want to beat those things up. I mean, we love to talk about piriformis release, and I mean, who enjoys that? Nobody, right? Especially if you're going to do that kind of active release, internal, external, for 5-10 minutes. Ouch,
Yeah.
right? So for me, if I can drop a couple of needles in that piriformis, induce a length change or perhaps a neuromuscular change, and the needle initially, they get some discomfort as the needle enters, but it sits there, works its magic, and I'm not having to move and manipulate, and they're comfortable with that. And the other thing that I use it quite a bit for is lumbar stability. We have found that, and we know this from literature from Joel and Richardson and Hyde and all these researchers that found that the multifidi are traditionally inhibited after any bout of back pain, and it's pretty difficult to get them turned back on. And if you can drop a needle down into there and then run some current through there, it's telling the brain, hey, we got to wake these guys up.
Yep.
And it's a heck of a lot better than just trying to dig down in there, which most people don't, but we try to do these neuromuscular reactivation techniques, low level counter rotation drills or prone minimal Superman exercises to target the multifidus. But if I can put a needle there, I mean, I know what's there and I know what I'm hitting. And so I guess that probably answers most of that, but I think it's areas that you can and need to be specific. And that's what's beneficial, is I know where I am and I know what I'm hitting.
So what you're really alluding to is, dry needling is very specific for a specific outcome, right? I'm not going to use a hammer for everything I'm going to use to build the house, right?
Sure.
I may need to use a screwdriver.
Absolutely.
Right. All right. So let's go back a little bit about, you've mentioned now, I think 3 or 4 times, I'm going to use the needle with some current. And obviously you're referring to e-stim, and then let's end on this.
Okay.
You can attach e-stim to some needles,
Absolutely.
right? And is there a specific setting that you like to use?
Yeah, and again, it's the same settings you would use for traditional e-stim. If you're looking for a muscle contraction, where you would use maybe a hertz that would be around maybe 60 to 70 or pulses per second anyway, 60 or 70 to 80. Whereas if you're looking for more of a slow kind of chronic pain, you may go with the lower 8 to 12, which has been studied, or even lower than that, or you could go very high, 150 to 200. And again, it's the exact same way that you would typically use E-stim anyway. I'll be honest with you, I like the mid-level volt, or the mid-level pulses per second that encourages a muscle contraction, because I find neuromuscularly that having a patient contract or a client contract is more beneficial, because it's recruiting more of those big myelinated fibers, right? Because we're inducing a contraction in a tissue that may not be able to get to that level.
All right, I think that you're getting summons to demonstrate some of this, right? And, so we got to get back on track here.
Absolutely.
Would you come back and talk to us some more? As a matter of fact, I'd like to invite you maybe to our program and give a demonstration. Kevin Maloney gave a demonstration, I think it was last year. Kevin is an adjunct instructor for me. So maybe we can arrange sometime you come in, and I have some tight spots.
There's always that, right?
Right. I'm going to identify 4 or 5 spots.
I'm assuming I found a volunteer.
So. Go and fix some people.
I will. It's a pleasure.
Good luck with Kilimanjaro.
I'll send some pictures.
Yeah. And then, so Stacy, let's have you move over to the hot seat. Yeah. Okay, man. Talk to you later. Again, if you want to look up Chris's segment, you want to learn more about Chris, it's sportsmedicinebroadcast.com/Chris Juneau 2016. And in with Chris now, or in right after Chris, is Stacy Latham. And Stacy, hi, how are you?
Hi, I'm well, thank you.
Yeah, you're welcome. You are on the Sports Medicine Broadcast, and this is a podcast that is everything athletic training and sports medicine. So here's, we want to talk just briefly a little about your background, what you do, and how you got to where you are, and how you think I'm like the greatest guy in the world. So
I might have to leave before we get to time for that segment.
Part. All right. So let's talk a little bit about your background.
So I earned my bachelor's in athletic training from the University of Northern Iowa, probably in its first accredited education program class back in 2002. So then I earned my master's in exercise science from Central Missouri State University. And then have held some different positions that,
such as?
Well, it's an interesting resume that I built up, and that's probably what led to me having the position I have.
What are some of those more unique?
I kind of took a little traditional role at first, coming out with my as an athletic trainer. Worked in the collegiate setting at the NAIA and Division I level as an assistant athletic trainer. Instructed classes in an education program. And then I went and worked on the railroad as an athletic trainer.
And what did you do on the railroad? Were you laying the tracks?
No, they did let me drive a train, which it's not that hard, and it's probably not kosher that I say that, but that's okay. I did injury prevention and health and wellness education in a system in the Midwest, and did presentations to groups on all 3 different shifts throughout a month. So I saw roughly 800 workers in the industrial setting working, repairing. They repaired engines on locomotives and did car inspections. And I worked to help repair them. It was a pretty interesting position and definitely made me work outside my comfort zone in a lot of areas that I would never have thought I would have done or somewhat enjoyed, but it was definitely not the most pleasant work environment for those workers or myself.
So one of the faster growing areas in athletic trainer is the athletic trainer that's based in the industrial and occupational setting, right? And I think the reason why that is because the athletic trainer really specializes in prevention of injury and illness and wellness protection, and combines that with immediate care and clinical evaluation diagnosis. So you take all of these skills and you have some really unique, you have really unique employment history. And so let's fast forward to NASA.
Yeah, I also got the opportunity to work in corporate fitness, and then collegiate rec in the fitness department as well. So that kind of steered me into working more in that general fitness, strength and conditioning area, which then, my job I work for a Wiley, like you said previously, and I'm contracted to NASA. And my job then entails being an athletic trainer and, a strength and conditioning professional as well. So I think my abilities and my experiences in the past definitely meld together to make me very desirable for my position, but it made that position very desirable to me. I didn't want to just be an athletic trainer anymore, and I didn't want to work primarily just in fitness. I love both aspects. So for me, this is ultimately a dream job. And then the fact that I get to help people go to space is pretty awesome too.
Right. And so now there's literally this podcast kind of goes nationwide, and I'm sure you got everybody's attention that you are an athletic trainer at NASA.
Mm-hmm.
And so you work directly with the astronauts. How many astronauts are in the astronaut corps?
Currently, we have about 47 crew members.
Mm-hmm. And you interact directly with those astronauts that are up on station.
Yep.
And when we talk about station, we're talking about the
International Space Station.
And so
we still have a space program. It's very active. We get that quite a bit as athletic trainers for the astronauts.
And so you're dealing with these astronauts, and they're all type A personalities, right? They're human beings just like anybody else. And so let's kind of go through a day in the life of the athletic trainer that works with astronauts. So you start your day when?
It can vary. Usually I start my day around 7:30. I work with two other people that make up our team of astronaut strength conditioning rehabilitation specialists. So between the three of us, usually we have somebody in there early morning to see our early morning people. We have a group maybe that's in there early morning. We have our regulars that are in there in the afternoon, and maybe we have our regulars that are coming in, right around that 4 o'clock time period as well. Seeing those people that are in early morning, interacting with them, and it's similarly to, working in any gym, you want to develop those relationships. So I'm not necessarily just there to watch how somebody's squatting and to critique their form and their technique, although that might be what I'm doing as I'm asking them how their weekend was and, what their day is planned. But, it's building those relationships because we're going to work with people for quite a bit of time. Our crew, when I say people, in their preparation for their mission, during their mission, and then after their mission. So in that time period, one of my coworkers, Mark Williams, put it really well the other day. As an athletic trainer, maybe I was working with one team that was in their season. So, they have preseason, in season, and postseason. Well, I have crew members or athletes that are in all those phases of a season at once. Mm-hmm. So I may have people, that I'm working with that are on station. I might have people that are getting ready to go, and I might have people, that are getting back from or doing the reconditioning aspect. So that makes up, working with those individuals, makes up different parts of my day. We also are in charge of doing the ARED PT. And
let's back up, right?
ARED.
You and I know what ARED stands for, but you have literally, I think, other than maybe 6 people on this planet understand what ARED is. So back up and explain to our listening audience what when you talk about, and I kind of want to back up here. You're getting ready. You're getting the astronauts ready to go up on space. So let's just address this. What type of forces, right? So they're going to launch out of where? When they go to space, they're launching out of
in Russia, near Russia.
Okay. And they're going to be on a rocket called a Soyuz.
Yeah.
Okay. And they're going to take off, and they're going to reach how many G's?
Oh, that's a question for somebody that doesn't work in a gym, probably.
So
I don't have that one right off the top of my head.
And so they are flying to space. I think it takes about 8 hours to get there, right?
Ish.
And they have to be kind of cooped up in this little tiny seat.
Yeah, it's probably about about 100 plus degrees of hip flexion. You're at at least 100 of knee flexion, and you're there with 2 other people, and there's
you've got
not
to
a
be
lot
in
of
that.
space.
Yeah, you got to be in that
Yeah.
position for 8 hours.
Yeah.
And so first and foremost, right, we're working on flexibility. You're working on all those different things. Okay, so you're getting them ready, and then they got to get up on station. So, like everybody else in the world, they saw one of the U.S. famous astronauts, Scott Kelly.
Mhm.
Okay, he's all over Time magazine, all of those stuff. And so Scott Kelly just, he arrives on station, and let's just assume that he's going to follow all the normal protocols, etc. And so, you're dealing with one population that's getting ready to get up there. And now let's talk about the population that's up there. Talk about some of the devices. So what does ARED stand for, and what other devices are there?
Well, ARED is our resisted training device. It had a predecessor called IRED, and before station, we didn't really have a need for a resistive training device. So that's
Why?
what that was developed.
Why?
They were short duration missions. Most shuttle missions, last shuttle mission was in 2005. So, prior to station, the assembly of station, and then being on station, just nobody was there that long to have some of the effects that space has on our body.
So what's the difference? A shuttle mission lasts, 10 to 14 days?
Roughly, like about
And
2 weeks, yeah.
When somebody goes up on station, the normal length of stay in space is for how long?
About 6 months.
So there's a huge difference, right?
Yes, yeah.
There's a huge difference of what space can do on the body.
And so what we call what we do and what ARED does, and our other 2 devices up there, T2, which is our treadmill, and CVIS, which is our ergometer, kind of our bike. It kind of acts more like a unicycle than any bike that you'd see like in a gym or a fitness setting. But prior to that, sorry, I lost my train of thought, but prior to that, we didn't really have a need for it. But we know that we do now, because we see, muscle loss, we see bone loss because of those extended stays, those long duration stays in space. So
then that's the second population. And now the astronaut comes back down, and, they just come down to Earth, and they got to get on a plane.
Yeah,
and NASA flies them back home. And
first
then they're
they
back
gotta-
with you.
Yeah.
Right?
First, they got to get out of Soyuz, which they're assisted. They have a great team in Russia that gets our returning crew out of Soyuz, and they carry them out, and there's medical testing that's done right there on site.
So what kind of medical? I mean, without revealing too much.
Yeah.
We're testing to make sure that.
Primarily to see
still
how
a human
things
being.
are. Yeah, exactly. That everything is pretty well okay. That they can safely put you on a helicopter that will take you to the airport, that will put you on a plane and start the journey back home. Our crew members direct return from Russia when they land. So we usually will see them about a day later from when they land to when they come back to Johnson Space Center, and their ACER that's assigned to them starts working with them.
Starts the reintegration rehabilitation protocol.
Yeah, we call it reconditioning. We want to, as you had mentioned, part of our group, we have 1 strength conditioning professional, and we have 2 athletic training professionals. So we're all assigned to different crew members. So we work, somebody's entire prep flow, which is 2 years prior to launch, their mission, and then their reconditioning. So they land, R+1, return +1. They start working on stuff, and so we refer to that as reconditioning. And depending on the individual, we start everything relatively easy, so to speak. We're looking at their strength, we're looking at their balance, we're looking at their proprioception, we're looking at neurovestibular function. In a lot of different ways, and then providing exercises based on that. And usually our reconditioning lasts about 45 days.
So you mentioned, I'm not quite sure if our listeners picked up on it, you're getting them ready for this for 2 years.
Yeah. So usually our crew member is assigned to a mission 2 years prior to their mission. And so we know, as ACERs and other people in the exercise and medical aspect of at NASA, the better we can get somebody beforehand, the better they're going to feel in space and the better they're going to feel afterwards. And I think, most athletic trainers can relate to that when either if we're working in the industrial setting, in a sports setting, the better you can get somebody prior to an event, whether it's work every day as, a factory worker or, a football player or soccer player, however best you can condition them for their job to meet those demands, they're going to be more successful doing that. You're going to prevent other issues.
Any injuries or anything like that, the better off they're going to be able to recover.
Exactly. So, that's why it's
so
awesome
these are all the
to-
same concepts, basic concepts. Obviously, you've got some specialized training specifically in that industrial and occupational setting. So let me ask you this question, right? A lot of people are probably going to listen to this and they're going to be like, wow, I want to be an athletic trainer and I want to work with NASA. What are some of your recommendations?
Well, honestly, I never would have thought I would have worked for NASA, let alone, work with astronauts. Driving, to JSC every day for my job is still pretty pinch me, unrealistic. But I think just my passion and my desire is a huge aspect for not only me getting the job, but for anybody else. I mean, I have a huge passion for athletic training and for fitness, exercise, and strength conditioning. So I've made myself, that's my driving force for learning more, for applying more. Find your passion. That's what's going to get you where you want to go. And, you might kind of weave a little bit on the path, and that's okay. I certainly did, but I don't feel like I would have gotten the position that I have, which it is a dream role for me. I never knew this job existed, but being able to integrate the aspects of athletic training and exercise together in the role that I have is a dream job for me. It's just icing on the cake that I get to work with the people that I get to do, not only on the team that I'm at with Acers, but then the crew members, because they're pretty awesome. And they do a lot, just being astronauts and the work they're able to do when they're on missions and the experiments and the science that gets to happen and how that translates then to so many aspects of what we do as people, but then also in the healthcare profession and also in athletic training. It's tremendous.
And so inquiring minds want to know, have you ever gotten a call from space?
Yeah, I have. It's pretty funny when you see a number pop up.
I have to step out. What's so important? Well, this is space. So tell us, I don't want to know the contents of the call, but kind of tell us what happens. So you're there, maybe you're at dinner or maybe you're whatever it is, and the phone rings. So set us up. Where were you? The phone rang, and it's one of your patients that happens to be an astronaut that just has a question.
Well, I mean, we're actually all in our office not too long ago, and we get a call, and it's like, oh, well, you see this number that comes up, and you're like, pretty sure this is the number for the space station. So it's not like we can call them back necessarily, but
sorry, I have to put you on hold. Could you imagine the data charges for that?
We just let it go through mission control. It's all covered. But yeah, so crew has maybe a question about maybe one thing that you've changed in their protocol, because everything they're doing on the pieces of equipment, that are our countermeasures for the effects of the body on space. We do all that and we adjust that accordingly based on their needs and kind of what's going on. And just like any other person, when you're working with them on any other program, you're ready to adjust and be very fluid based on what's going on. So anyway, it might be something simple as that, and that can be addressed pretty quickly. And then they, want to chat because they're a person too, and they might be up there with 5 other people.
And they're just up in this box.
And they just want to know what's going on. They want to hear the juicy gossip maybe, or something, hear some jokes, hear the old familiar laughs of the nice Acers in the gym. So.
Because they're gone for 6 months.
They're on for probably a little more than 6 months. They usually leave about a month prior to launch to go to Russia to complete some training and some of the formal ceremonies before they fly. And so really the last time you see your crew member is probably depending on the length of their mission, which can be adjusted based on all the things that are going on, launching people into space,
Right.
but you don't see them for like 7 months. So you develop a relationship with that person, just like we all do with all the people we treat. And it's nice to just chat.
And that means kind of psychologically for them too, if they're married or they have kids, they're not going to see their spouses for 7 months. They're not going to see their kids for 7 months. They're going to be up in space, and they're going to miss birthdays and anniversaries and all those different things. And so there's a whole psychological component to what you all are doing too.
Yeah, definitely. I mean, it's really valuable and really important, the work that our crew is doing, and we're happy to be someone that in a group that helps facilitate that and provides them with the resources like ARED, T2, CVIS to be able to do that and to feel good. A lot of them, maybe aren't huge exercisers prior to launch, but they see it as not only a way to improve their health, or to maintain their health, I should say, but then it is a big release for them to take that time to be able to do some exercise on their own and kind of have a little me time up there too. So
we're going to wrap up here, because I think Ryan Collins is probably going to get in. He's going to be talking about something that you may be interested in. It's returning the injured shoulder.
Yeah, we,
Right.
the average age of our astronauts is in the mid 40s for our men, and early 40s for our women. So as a person ages, we see an increase in injuries in active individuals. So that's no different from
Anybody
an
else?
astronaut or anybody else. So.
And so one of the things about the astronauts too, I mean, these are some of the smartest people I've ever met, but there are engineers and physicists and physicians, and I mean, they're just normal people.
They're normal people. We have quite a spectrum of whether they are military or civilians. We have some of the smartest people who have worked on some of the most amazing things. And, we have people who are former student athletes. We have really highly motivated, highly driven people who, make jokes about silly things just like the rest of us.
And so if somebody wants to learn more about this role or learn more about your path, right? Because they're going to go through athletic training school, and they want to look at emergent settings, whether it's going to be an athletic trainer in physician practice, athletic trainer in a hospital practice, athletic trainer in occupational industrial practice. Can they get in touch with you?
I've never really thought about that.
And so as you give some more thought to it,
Okay.
if that's something that you want to share, obviously that's totally up to you. If that's something you want to share, then we can go back and we can put that information up on the Sports Medicine broadcast.
Oh, okay.
Right. So if somebody wants to get in contact with you, you're like, hey, Stacy, I heard you on the Sports Medicine broadcast, and I want to learn more about your path and learn more about kind of how to get to that, whether it's with NASA or the police department or the fire department or military, whatever it is.
Yeah.
We'll go back and address that later. Okay.
Yeah, unfortunately, there's only 2 athletic trainers right now for our astronauts, and we're not leaving our jobs anytime soon.
Yeah,
so
right.
There's not really an opening.
And so let's there are, and I've gotten this question a couple times, there are 2 space centers, right? There's the Johnson Space Center, the Kennedy Space Center.
Yeah.
And there are athletic trainers at both.
Somewhat. There are some that work at Kennedy, from my understanding, with some of the other non-crew
Right.
individuals that are there. So it's definitely thinking more of like the industrial type job there. I know it's not within the company I work for, so I don't have a lot of information directly about what their roles are. I know that when and if we are launching out of Kennedy again, it'll be people within my group that will take care of our crew there.
And so the
That's
major
case.
difference between the athletic trainers at the Johnson Space Center and the athletic trainers at Kennedy Space Center is that really the Johnson Space Center, those are the athletic trainers that have one-on-one direct access and patient care with the astronauts.
Yes, our primary role is part of the flight medicine clinic at Johnson Space Center, and we work directly with our physicians, who our jobs are to treat the astronauts.
Great. Okay. We'll let you get back to the conference. I really
Okay.
appreciate you making some time to come to talk to us and the
Great.
show and people learning more about it. If and when you decide that you want to share your contact information, we can do that. If not, that's okay too. Again, Stacy Latham, athletic trainer,
Yeah.
astronaut, strength conditioning, and rehabilitation specialist with the Johnson Space Center at NASA. Thank you very much for your time.
Thank you. Is this just audio or audio and video, Josh?
It's audio and video.
Oh, okay. Oh, okay.
Yeah.
Awesome.
So you can.
So, yay. Thanks for that heads up. No.
Sorry.
I would have said no.
All right. Audio looking pretty level.
Is this my turn?
Yeah.
Hey, Jeremy. I'll be right there.
Cool.
Break this stuff, dude. Still running live. Let me switch over to this other seat here. Did you turn any of the mics down? Yeah. Getting started. What's up, y'all? Welcome to the Sports Medicine Broadcast. We're at the 15th Annual Sports Medicine Update. We're at the 15th Annual Sports Medicine that was hosted by Memorial Hermann and UT Health. I want to thank Bob Marley for letting us come out again, do all these interviews. Ryan has been on the podcast multiple times, helped out with some of the interviews last year as we did this. So, Ryan, you talked about returning the injured shoulder to the weight room, and you're about to lead a breakout session. So this may be a real quick interview, but tell me briefly, what was your topic?
So what I was trying to hit on was the kind of the next step, the next phase in shoulder rehab. A lot of times after individuals, athletes, recreationalists come in for shoulder rehab, they kind of leave having good strength, good mobility, but they have those next levels of strength and aspirations to return to their sports again. So my talk was kind of hitting on some of the exercises, some of the issues that can limit their full return to full capacity, working on performance improvements and things like that, and trying to tie it into eventually returning to a sport or just getting back into hitting the gym.
All right, so you said some of your feedback is that you've gotten is seeing the exercises performed. Well, why do you think that we as athletic trainers most of the time would rather see you perform or have you show us the exercises than teach you how or why to do them?
Well, I think, you might, well, it depends. If you're somebody who's going to look further into exercises and you have aspirations to, dig deep into the realm of strength and conditioning, you can come up with these exercises. That's kind of what I did. As trainers, you guys are kind of that intermediate step between a rehab and a full strengthening conditioning program. So a lot of times the feedback I get is, hey, show me demonstrations, exercises that kind of I can use in the training room, because you may not have access to the full gym. And so what I try and do is give you guys examples of things that you can do with minimal equipment, but still address the major deficits, the major limitations, the major muscle groups that need that next step in strengthening to return them to their strength and conditioning program with the team that they're going to go back to.
Okay, the 3 exercise videos that you showed were along those same lines. Why don't you tell me what those were?
One of them was the tall kneeling landmine press. And what's good about it is that you get into half kneeling landmine press, is you get them in a half kneeling position, which is basically one knee on the ground, 1 foot front. And you load up a bar, the landmine, you load up a bar, and what you're doing is you're really pressing more into a 120 degree, more of an elevated position rather than like a flat bench press or an incline press. You also have them without support of a bench. So you recruit the shoulder force couple muscles really well. You get the upward rotation of the serratus because you're pressing into a ideal position. You get the mechanics of moving the shoulder blade on the rib cage, which is real important for all pressing motions, retraction motion. So it's a good way to kind of get all those areas hitting at the same time. The external rotation and overhead press is something Mike Reinold posted. He's a big shoulder guy. It's one exercise that I've found that really hits the posterior cuff, the rotator cuff muscles. A lot of times the guys who are performing it really get that kind of metabolic burn that you feel, getting that kind of that pump feel, but it really kind of helps fatigue out those muscles, which is important because you want your rotator cuff kicking in when you're doing things overhead. So it's a good exercise to really work on alignment. And then the last one was a kettlebell overhead press. When you turn the kettlebell upside down, really make sure your grip and your rotator cuff have to really work. The harder you have to squeeze, the more radiation you get to really tighten up that shoulder. And so with that kettlebell overhead press, it's less weight. So you're not trying to overhead press a lot of weight too soon, but the instability of the kettlebell requires a lot of those muscles to kick in a little bit harder. So it's a good way to make sure everything's recruiting well.
All right, so for me, 35-year-old father of 3 boys, right? How important are these exercises, or how beneficial would it be for me to use these in my regular workout?
Well, I think they're a great transition to just overall health. As we get older, we slowly creep away from those dynamic activities that we got to perform when we were younger. And so we may lose our ability to really get overhead without compensatory motions. And if you have aspirations and goals to be strong and stay strong and avoid injury, the best thing you can do is to make sure all those muscles get their work and they get worked in the optimal positions. These exercises are safe as long as you do them appropriately and you have proper mechanics. And I think the good thing about them is they easily transfer over to somebody who's learning how to do them because they're not all that complicated. And if you don't feel like you're doing it right or you can't do it, it either means you need to work on it or you have some sort of other deficiencies that you need to address. So somebody who's 18 all the way to 35 and then older, as long as it's something that you need programmed, if you want to play sports and you want to shoot baskets and you don't want to worry about a recurring shoulder injury creeping back up on you as you get older, then maintaining that strength is important. So yeah, for sure, keep going.
All right, and one of the things I heard you say in the talk was if you're doing like a rowing motion or doing the push-up, whenever I feel my shoulder blades pinched together, that's when I should stop, because I shouldn't set the scapula and then do the rowing motion. Because when I was doing, like during college, my days, I remember the physical therapist specifically saying, you want them to set the scapula, and then, so basically making a row like a 4-part motion. Like set the scapula, you pull back, you go forward, and then you fully release the scapula. To explain that a little bit further.
Well, I think, and I was a tech and I went through PT school and even coming out, that was a popular cue was to set your shoulder blades back and down, pinch, right? Pull back and down together. And I think what was trying to be accomplished was you're trying to get that lower trap recruitment to help set the shoulder blade in a good position. Anytime your lower traps turn on, you kind of open up that subacromial space, so you allow for more motion to occur without impingement. But what goes on whenever you actually move during an exercise or even some sort of dynamic activity is that they move in coordination with each other. They move in concert. So there's not an independent movement followed by an independent movement. And so what you really have to try and cue someone who's either relearning or has a little to no experience is that you want those shoulder blade muscles to act with the glenohumeral muscles so that you keep that glenohumeral position in line with the humerus. So if that scapula is moving, then you want that socket and that ball to be able to move together. It also helps with joint centration, which is important for your rotator cuff to keep that in line. So importance is the cueing it correctly. So a push-up, as you drop down towards the floor, if your shoulder blades are actively retracting back as you drop, you're keeping everything in good alignment versus going all the way down and letting your elbows go way past your body. You can get a lot of anterior stress with a row, standing, bent over, inverted, whichever. Moving your shoulder blades on your rib cage at the same time. Whenever you feel your shoulder blades can't move any further, don't finish the motion by just extending with your humerus because you're going to get that stress to the front. Work on thoracic mobility if you don't feel like you got a lot of range, but really move through the shoulder blades. So therefore you're working the shoulder blade muscles, and hopefully that carries over to the strength whenever you perform it dynamically.
All right. So do you feel that there is a place for cueing single muscles like we were just discussing, maybe in like just post-surgery you're retraining that one muscle, but if you're teaching strength or dynamic movement, then that's when you need to work on the entire motion. Is that kind of what you're saying? Yeah.
So isolated work definitely has its purpose. The talk that I put out there was definitely focused more on I'm after rehab, I'm back into decent strength, but I want to go into the next level of strength and strength and conditioning camps and get back with the team. So initially right after surgery, a muscle shut off, and we know that with the knee, with the quad, but also somebody who's just had bad mechanics their whole life, they may not know how to actively retract the proper muscle. So getting them to turn on the lower trap a little bit more. But as you mentioned, as they get further and further out from that initial injury, getting them to do it in concert and coordinated movement.
All right. So Ryan Collins and Paige, do you have a social media yet? You got on Twitter?
No, I'm not on Twitter. No, I know.
I'm not. Tell everybody you're on Twitter. All right, so hit up Ryan. We'll probably talk to him again later, or he'll probably be in private interviews. So go do your breakout session, and I'm going to come catch up with you in a second.
Appreciate it, guys.
All right, this is Jeremy Jackson, sports medicine broadcast. Dr. Josh Yolen has been running most of the show for me. This interview will be sportsmedicinebroadcast.com/Ryan Collins 2016, or for those people who, my son actually corrected me the other day, it's 2016, Daddy. So it's Ryan Collins 2016 at the end of sportsmedicinebroadcast.com. So that way you can find this interview once it's released again, and we'll have the interview or the actual session as well. So those will be released separately. Again, we're at the Memorial Hermann Sports Medicine update. Thanks to Bob Marley and the whole Memorial Hermann team. And thanks Jasmine Dozoff for doing all this recording work, and Nicole Kasha for doing all the work in the other room.
So while we have a little break, I wanted to put Nicole Kasha on the hot seat. She just graduated with a Master of Athletic Training degree from the University of Houston.
Congratulations.
Right?
That's true.
You have a piece of paper now, right?
I do.
It
I
got mailed
actually
to you.
received it yesterday.
That's pretty cool.
Yeah. I'm going to frame it.
And so you took your board of certification exam, and you accepted a residency program position at Ben Hogan Sports Medicine.
Correct.
And so you have a lot of people that are going to be listening to this broadcast that are probably thinking, maybe I'm an undergraduate, or maybe I'm in AT school now, and I want to go for a residency program. So I want you to discuss a little bit about your experience. Why did you choose to pursue a residency program? What do you hope to get out of it? What has the process been like so far? How great the MAT program at the University of Houston was, how amazing your program director was. I mean, from what I understand, this guy's incredible. All your experiences leading up to this point. So let's start from going back in time.
Very beginning.
Huh?
The very, very beginning.
Yeah,
I remember.
Let's start from the beginning.
I actually remember doing when Jeremy came to our round table classroom, and it was his first time with us, and he was talking about what we wanted to do, and I was speaking, and I was interested in
NBA, like women's NBA basketball then, and now I'm like a completely different route. So the past 2 years during the program, I've kind of like figured out what I don't want, what I do want, gone back and forth a lot. So the opportunities that were given to us during the program helped me make those decisions. So even I would go after things that I knew I didn't like, but I wanted to make sure that I didn't like them, so I still tried them anyways. Like high school, I know I didn't want to do that, and then college, I know I didn't want to do that, but I still gave it an opportunity. I still worked for the college football team and went to the PT clinic. I did like OR. I was in the operating room a few times. So all the opportunities that were given through us throughout the past 2 years helped me make the decision now
So
for the residency.
you got to experience the entire spectrum of what athletic training is now, right? And so at some point you decide that, you know what, I want to pursue this residency program. Why?
I had no idea even residency programs existed for athletic trainers until like a few months ago. I think it was like November. And whenever I found out about them, I thought it was a great opportunity for us, especially coming right out, being an independent clinician or independent healthcare professional. How ready are you? And that's something that the residency program can help you figure out. And also it depends on the type of residency program that you're going after, because there are many different kinds. The one I'm a part of is biomechanic based. So they have motion capture cameras there, and we'll be doing motion analysis. And
so why, and by the way, the director up there, I think he does just an outstanding job. I think he's great. Craig, if you're listening to this, you know, he's doing great, right? And there are all sorts of different types of residency programs. Forrest Pecha, who he was at the Stedman Clinic, and then he went and he started up the Emory residency program.
More physician-based.
Yeah, and then he's over at I think it's St. Joseph's in Idaho. He's been great. And so tell the audience, tell the listeners, why were you interested in this one? Because what they need to understand is, I think the thought process is like, there's one residency program, there's one type, right? But there's not. There's all right. There's all these different. So why was this program interesting to you?
So the residency program over at Texas Health Ben Hogan Center, they do a lot of work with the baseball athletes, and they work with those who are post-op ACL, and they do preventative research. So whenever I was this past year with my mentor, Haji May, he kind of showed me and helped me open my eyes to the importance of biomechanics and treatment in rehab, in prevention. So I figured if I could learn as much as I can about biomechanics, I'll be able to help treat an athlete or anybody, any sort of athlete or those who are active patients. I can help treat them and understand the body and its mechanics and injuries a lot better. So I knew I wanted a more depth knowledge base on it, so that whenever I go and I am an independent clinician, I have a better background on that specifically. So, and I knew that they would provide that there for me over at the residency.
And so for those that are interested in, maybe they're finishing up AT school, maybe they're thinking about a residency program, tell everybody that's listening the process that you went through to get to this position, because I think that you were, what, 2 of 100 people selected, right?
Yeah, there's over 100 people that applied throughout the entire country. So it was a lot of networking, a lot of communicating, a lot of putting my name out there, being involved. I would go to symposiums and I would go to different conventions and just get to know everybody who's part of that team at Texas Health Ben Hogan, and also those who Texas Health Ben Hogan associate themselves with. So I knew a lot of people that were really close to Craig, and I would communicate with them, let them know, look, this is what I'm interested in. This is what I know. Not only can Texas Health Ben Hogan provide me with a lot of information and knowledge, but I can help them out, and I can bring some of my knowledge that I've learned. So I can, not only are they going to do something for me, but I can also do something for them.
And so you really talking about when you were in school, you took advantage of every opportunity, not just the opportunities that the program provided, but other opportunities that you sought out for yourself, right? I mean, you were totally 100% invested in where you're going and the path and the success that you want to be able to create for yourself. So you chose Ben Hogan. When do you start?
August 8th.
And so you have to move. You are born and raised in Houston?
No,
Right? Or you were born.
I was pretty much raised in Houston, but I was born in another state, Wyoming.
Okay. So you're raised in Houston, and you've lived in Houston. You went to undergraduate in Houston, and then you got your master's degree in Houston, and now you're going to move out of Houston.
Correct.
Right, and you're going to go up to Dallas.
Yep.
And so you are going to go up to Dallas, and you start in August. And do they have a prescribed rotation for you, or what are some of the things that you're going to be doing?
So one major thing is we have to propose our own research project that we're going to work throughout the entire 12 months. So we can choose whichever team, because they work directly with TCU. They have an association there. So we can choose whichever sport that we want to focus on. I'm going to be doing baseball because that's what I'm most familiar and comfortable with. And then with that, we're conducting our own research that we present at the end of the year, which I just went to the ones of the 2 current AT residents who are there. I just saw them present about a month ago because Texas Health and Memorial Hermann actually worked together, and they shared like a research day where they shared information. So throughout the entire 12 months, we work on this project, and at the very end of the year, we present it.
And that presentation, it's like a case study.
Yeah.
Have you ever presented a case study before?
I sure have.
How about that?
Yeah, but this is a little more intensive because we're having like 500 subjects.
I get it, but you've already done it and you've already seen it. Okay, so it's a 1-year residency program. And what's your goal after that?
So I'm hoping to perhaps pursue a PhD. It depends what I learn, what I can get from the program, but currently I was looking at PhD programs in applied neurodynamics because that's kind of goes hand in hand with biomechanics, and there's a lot of connections there. So if the residency goes well, and depending on what I decide to do my research project on, what I decide to do for my biomechanical analysis, if it goes well, then I'll hopefully pursue that PhD.
So you said that you're going to be working closely with TCU. Right, and their baseball team?
Yes.
And TCU has an accredited athletic training program. And their program director is Dr. Stephanie Jevis. And Dr. Jevis got her PhD at the University of Houston. So when you get up to TCU, let her know that you are a kook, and so is she.
Okay,
And
I didn't know that.
Well, now you know, right? This is all about connections and bridging and making sure that it's that quote, I think it's by Thomas Edison, if I'm able to see farther, it's because I stand on the shoulders of giants. And so, Nicole, you are at the top now, and your job is to stay at the top and keep pulling people up with you, right? And go find those people that are going to be able to help you and make those bridges and make those connections and keep climbing so that one day, right, you can come back, and I'm sure it will be Dr. Kasha, and we'll be sitting and we'll be listening to Dr. Kasha disseminate knowledge upon us. It's going to be incredible. It's going to be great.
Yeah, I didn't realize how close of a community athletic training was, but it's actually really easy to network within the athletic training community. It's everyone knows everyone.
And that's another great
So
learning lesson for everybody listening, right? Especially the students that are going through AT school now. Everybody is connected to everybody else. So what you do in one clinical education assignment and the impression you make will have some sort of carryover to everything else you do. And it's up to you to decide on whether you're going to make a good impression or a bad impression. And that will continue to follow you through. And whatever result comes out of that will impact your, ascension or descension through the program or through the profession.
It's true.
All right. Congratulations. If somebody had questions for you, Nicole, they're going to listen to this and it's like, I want to go into a residency program. I want to learn more about it. And I've got my eyes set on the Ben Hogan Clinic, how would somebody get in touch with you if they had questions?
So email, and I have a LinkedIn that I always check every day and I keep updated. So you can find me on LinkedIn or my email, which is my last name, Kasia, Cascia, and then my first name, Nicole, Nicole @gmail.com. Very easy.
Thank you very much. Congratulations.
Thank you.
This is exciting. Make us proud. Okay, bye.
Congrats on your. Thank you. How did you do well on your boards as well? Wow, but you feel you did well. Yeah. All right. So what are you gonna do all summer?
I'm just trying to start doing some of this. So is that what you do? Yeah. Yeah. Just like clean it up basically, so like somebody's coffee or things on the table. Do you know anything about I haven't asked him. I think he said round in Thursday. So we can come sit on Thursday. Oh, okay. He said it should be okay, but so we get like right? I don't know if we're right on the phone or he mentioned us two going together. But I don't know. Yeah. So I want to send both. I guess we can talk about it. But I don't know if it's because he has to take all your equipment and stuff. Yeah. Yeah. I don't know like any of the schedule, like how this is rolling out.
I think it's online. There's a trial at taking that.
Okay.
And so the like where it's gonna be at is at the hotel, so we're just going like driving there and just going downstairs. I think.
Do you think we should tell him? Puts you on the spot. Sure does.
I do really for big groups of people and loud noises. I like being in the corner of people.
Well, this is the spot to be.
Yeah.
Is it still going live or did you end it already?
Huh?
Is it still going live or did you end it already?
No, it's so